So you may have kidney disease and you've been referred to a nephrologist. What's going to happen now? I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We brought back a wonderful guest, Dr. Sanjay Bandaya, nephrologist. Thanks for being back.
Pleasure.
Okay, so things have changed in the landscape of nephrology, just like all of medicine, but you guys have really added a couple extra things in your toolbox. Once kind of diet and lifestyle have either stalled or the train, we've talked about this before, the train is heading toward the cliff of dialysis. You've got a few more things. Can you explain to us the treatment algorithm when someone comes to you and says, I got kidney disease and I want it to slow down?
Yeah, and I think that's important. It's probably the key question when patients come to see a nephrologist is what can we do about this?
Yes.
Right? And so historically, really what we had was blood pressure control as our only tool in the toolbox, if you want to call it, to slow progression of kidney disease. And these are the particular class of medications that would be key, called RAS blockers. Okay, they're medications that end with pril, like perindopril, or end with sartan, like telmisartan. These medications, along with lowering your blood pressure, have unique properties within the kidneys to decrease the stress on the filtering head or these filtering units, so that you preserve them in the long run and prevent the development of end-stage kidney disease.
Okay, remember your kidney is a filter, and these RAS blockers, which we sometimes need in this talk here, I need a RAS blocker with this guy sometimes. So what you have is a filter, that's part of it's not working, the other part's working overtime, and these RAS blockers sort of tone down that one that's working overtime so it'll last longer.
Correct.
Basically.
That's right.
And the issue is that high blood pressure, so as your blood comes in through your arteries to your kidney, that can cause damage if it's too high. So we're primarily trying just to lower the pressure to protect the filter.
That's right. And so these RAS blockers, along with other blood pressure lowering pills, are key. But these are the crux of blood pressure lowering therapy.
Pril
or sartan.
Pril or sartan. Yeah. You've seen them. You're probably on them.
So that's what we had for about, I would say 20 years, maybe roughly around that time frame, until about 5 years ago when we started to have a series of other agents that we could use to prevent progression in either diabetic or non-diabetic kidney disease.
Okay, so new age of medications.
And is the approach uniquely different for diabetic versus non-diabetic as far as the medications that you choose?
At this point, there's some commonality.
Okay.
Like the RAS blockers would be for both.
Okay.
But there are some agents that work in both. There are some agents that have been proven in both.
Okay.
And there are others that have been studied in diabetic kidney disease, and stay tuned on the non-diabetic kidney disease, right?
Okay.
So when a patient comes into my office, I say we're going to use a staged approach to try and prevent your progression in your kidney disease, and that might involve anywhere from 2 to 4 agents, okay, depending on whether they're diabetic or not. And so the first agent that we would add on are something called the flozins. So this is dapagliflozin or empagliflozin. A lot of my colleagues refer to themselves as flozinators. So really these have become standard of care, particularly if you have any chronic kidney disease with protein spillage. Okay.
So the filter's leaking.
Right, and so these agents were first developed as diabetes drugs. Okay. And then they found some unique things about them. One is they prevent heart failure. And then when they did the heart failure studies and said, oh yeah, it does really prevent heart failure, then they found, oh, by the way, the offshoot of that is that it actually prevents some progression in kidney disease for patients who had kidney disease in the trial. So then there was a study by something called canagliflozin in diabetic kidney disease, which showed benefit in preventing progression of kidney disease and in preventing heart failure in that same population. Okay.
Is its mechanism like glucose, like serum glucose related to lower serum glucose?
Yeah. So there's a plethora of ideas as to why they work from the standpoint of preventing progression of kidney disease. But the way they work is they actually block a glucose transporter in the tubule of the kidney. Okay. Okay. And along with probably decreasing stress on the kidney, both by actually the flow at the filtering head, they probably decrease the workload of these filtering units. Okay.
Interesting.
So there's a bunch of purported reasons. So after the study was done in diabetics, then we had 2 other trials with empagliflozin and dapagliflozin that were with diabetic kidney disease and non-diabetic kidney disease. And obviously the concern is you're putting somebody on a diabetic drug. And when I first started prescribing this in non-diabetics, the pharmacies were like, Does
Yeah.
Dr. Pandya know that you don't have diabetes,
Yeah,
right?
yeah.
And really what these agents
Did
use.
you go like this? Duh.
Yeah, well, I said, yeah, I showed them my medical degree. So,
That'll work.
so you know, what happens is that these agents don't actually cause hypoglycemia.
Okay.
So there's no risk to that when you're on these agents. Right. And so these agents then, the empagliflozin and dapagliflozin, were shown in non-diabetic kidney disease along with diabetic kidney disease to prevent progression in kidney disease, lower incidence of acute kidney injury, and again, cardiovascular benefit.
And these drugs, ironically, now you would not say they're not really first-line diabetes drugs. Like they never became that, right? Like with like insulin and metformin and other drugs, it's not really used for diabetes necessarily anymore.
Right. So
just for the kidney side.
That's right.
Yeah,
So
wow.
any diabetic drug that comes out now can't just lower your sugars.
Right.
It has
We
to
got
have
stuff for that.
some
Yeah.
end organ benefit, either brain, heart, kidneys, eyes, something. It has to have some benefit.
Wow.
And so these agents now actually, we deem it a kidney drug. The cardiologists deem it a heart drug.
Right.
Right. So
Yeah.
this is now not. We don't use it for sugar control.
Right.
We might
Yeah.
modify some of the other diabetes medications you're on,
Yeah.
but they're actually a kidney drug, a heart drug.
Amazing.
And then they've been shown, you know, to have a wide array of beneficial
So two
effects.
things. One, any pharmacist watching, we're sorry, we're not dissing you. I love it when they double check my stuff, and I appreciate
Me
the phone
too.
calls from the
Thank you.
pharmacists. So thank you, pharmacists. Two, this is incredible because this is a medication that doesn't just treat symptoms or immediately treat the disease. It prevents progression. Like, and we don't have that in our world. Like, we have patients coming in asking us all the time for the conditions we look after. Well, what can I do to slow this down? What can I do to stop this? Do you have any medication that'll stop this? And they bring in articles and things and websites they've seen that things say they'll slow down their arthritis, but we don't have anything like that. That's amazing that you guys actually have, in the last 5 years, medications that can slow down the progression of the pathology.
Yeah.
Very cool.
Yeah.
Okay, flozins.
Flozin. So that's a flozin. So RAS blockade and with blood pressure control, along with the being a flozinator.
Okay. Would you start with those two probably? Like someone's to you? We're gonna start with
Generally,
two.
that's what I would
Okay.
start with in that order.
Got it.
And then we talk about an era now where we have, just like with the flozins, we have studies in diabetic kidney disease first, and then they'll likely come in and show benefit in the non-diabetic kidney world, but we're not there yet. But there are two other agents. One is called finerenone, which is something, it's the class of medication is a non-steroidal mineralocorticoid receptor antagonist, or an MRA.
Okay.
And the other is semaglutide,
Oh,
otherwise
okay.
known as Ozempic. So,
heard of that one.
so now everybody's ears perk
The
up
first
with
one's
that,
like,
right?
I never heard of that one.
Right.
Yeah.
So finerenone has been shown in diabetic kidney disease to prevent progression in kidney disease and also benefit from the cardiovascular outcome, including a composite of cardiovascular effects, including coronary artery disease, cardiovascular mortality.
And we've said this before, like the heart and the kidneys are so tied together,
Yeah,
and
they
more
really
and more and more so.
That's right. And so this agent essentially blocks a pathway in the kidney that relates to the end of what's called the renin-angiotensin-aldosterone axis.
Right.
And so it's this aldosterone receptor antagonist that actually helps prevent progression in kidney disease.
Wow.
So this has been shown in diabetic kidney disease to prevent progression in kidney disease, development of acute kidney injury, and cardiovascular complications in the range of 15 to 25% versus placebo.
Wow.
Yeah. So this now is recently got approval by by ODB. So it's covered for those who are 65 who meet the criteria.
Okay, in our province.
The criteria being that you have diabetic kidney disease as represented by protein in the urine.
Okay.
Okay. And this goes in conjunction with the other two therapies that we've talked about, which is blood pressure control with the RAS blockers,
Yeah.
and with the SGLT2 inhibitors, or the flozins.
Okay.
And then the last thing that we have, which is in a trial that came out last year, on a trial called the FLOW trial, used semaglutide
Yep.
in patients with type 2 diabetes.
Okay.
And as you can imagine, either they had a low GFR with low grades of protein in the urine, or they said, well, you could have higher GFRs, but you have higher grade protein in the urine, which means that train might be back here from the cliff, but it's going faster. Right? And so in that study, it was a composite endpoint of both kidney and cardiovascular outcomes, prevented a 50% decline in your kidney function, development of acute kidney injury, and also had cardiovascular benefit on a cardiovascular composite outcome.
Wow.
And it decreased that compared to placebo, again in the range of 20-25%.
Okay.
Okay, so I see decreased progression. Any aspect of reversibility where you only have to be on this for a while, then you can stop it, or is it you're on it, you stay on it for good, or were the studies not long enough to determine that?
Yeah, no, these are long-term propositions.
Okay.
So imagine if you have heart disease and you go on medications, you're on those medications, whether they're cholesterol lowering, which we haven't talked about from a kidney disease standpoint, but cholesterol lowering or your aspirin or other antiplatelet agents, you're on those for the long term.
Okay.
And these agents essentially you're on for the long term. They don't reverse your kidney disease.
Okay.
They just prevent this progression. But we've seen lots of patients who have actually had the slope or the decline in their GFR really quite normalized. And
Really?
and if you get all these therapies on, the studies will show that you can actually get that slope very close to zero, especially if we can minimize your protein.
Right, and that's the thing that's unique about the kidney, it seems. Well, I guess the heart too, if you have a heart attack, but the kidney gets that scarring of the filter or whatever, like irreversible damage by the trauma, and then you can stop it, but you often can't reverse it unless it's related to like dehydration or some specific insult that you quickly remove. Once it's there, it's kind of there.
Yeah.
Yeah, and thankfully we have a lot of reserve, so a little injury is not necessarily destined you to kidney failure.
I think the probably non-specific therapies that probably are worth mentioning is it's still important particularly in diabetics, to have good diabetic control, because that affects your microvascular complications like your retinopathy or your neuropathy, and it's important that if you should be on a statin, which is the lipid lowering therapy, then you should be on a statin. Okay, and there's certain criteria that we'll look at to say whether or not you should be on it if you're over 50 or if your GFR is certain value. But those are two other therapies that are
blood
not
pressure,
specific.
of course. Blood pressure. We
Blood
mentioned
pressure
in the previous video, just in case anyone didn't watch the previous video, blood pressure is key to control as well in this situation.
Yeah.
So kind of the take-home message is that there's hope. That's the first thing. I think need to let people come here looking for answers and hope. So definitely there's hope. It may mean that you're on a significant number of medications, just like when Mike Heffernan talks to us about blood pressure, often it's between 2 and 3. The average person takes 2 or 3 medications for blood pressure. They may be some of your similar blood pressure medications. Do you guys ever talk as cardiologists and nephrologists, say, listen, I'm thinking about this and you're thinking about this, can we maybe agree to do this because it can do both? I'm assuming that must be.
When you prescribe that.
Yeah.
Yeah, and very common. So because of, for instance, the flozins, it's about who gets them first. If the cardiologist hasn't put them on it, we put them on it. They're very happy that we put it on it. And it's important when you have patients who are under multi-specialty care, these agents are now, you have multiple touch points where these can be introduced, which is very important so that you're not delaying your therapy. And yes, we do pick up a phone and call our cardiology colleagues sometimes and say, hey, they're on this medication, but I think they should be on finerenone. I just did this yesterday. Do you mind if we flip that over?
Get rid of this one.
Because the finerenone had some benefits in a heart failure trial. And so we said, can we switch it? And then we're like, yep.
Awesome.
Wow. And if there was an award for naming classes of drugs, you guys would win it, because RAS blockers is cool and flozins is cool. We don't have those names.
No. It's okay.
Well, I can't take the credit for that.
But all right. You get to say it all the time. We only get to say it when you're visiting us here in the show.
But now you know all about the medications that can be used to slow down or potentially even halt your kidney disease and your kidney failure. If you like this video, please like it, subscribe to our channel, share it with someone that has similar questions to this.
Remember, get your RAS blockers and your flozins on if you need them. Thank you so much again for coming on our show and just spreading the wisdom. You're so smart. We love learning from you. Like our viewers love learning from you too. Remember, you are in charge of your own health.
We'll see you next time.